Welcome everyone to a nice Friday morning. This is our September education course sponsored by us here at Metrex. My name is Dave Nelson from Metrex Marketing, and I'm going to be your production assistant for the webinar today. I guess if everyone hopefully can hear me, I see attendees joining rapidly now. So we will have a short time here before we begin the actual webinar where we'll go over some housekeeping items for everyone for the webinar today. So we can go to that slide. Okay, if you've joined our webinars before, you've seen this before, so it's same ground rules as usual. The important things are we have a Q&A functionality in Zoom, and there is a chat window. So there are two different things in Zoom. So if you have questions, a couple of ways you can do it. You can enter them into the Q&A, and please use the Q&A window for any questions. If you want to hold your questions till the end, we will have Q&A at the end of the webinar. And if you want to ask your question live, Zoom has a function where you can raise your hand and we will recognize you and we can let you speak, and you can ask your question live if you prefer to do that. So either way, at the end of our presentation today, we will have a link to our survey. That's what will allow you to get CE credit for the course. We have to ask you to do a short survey. So it's not that big of a deal, but you'll get that link. And please, we'll give you a week to do that. So basically through next Friday, September 22nd, if you can get to that, do that survey. And then after you do our survey, it'll click you over to our CE providers tool, or Google Doc tool, where you'll need to put in your email address, where she will then get you your CE credit for that. Please use your personal email address. We have seen it where a lot of your corporate emails, your facility emails, the firewalls and some of the email systems will block her trying to reach out to you for your CE credit. So if you use your personal email, we've seen that work a lot better. So that's our tip for that. Upon completion of that, Terry Goodman and Associates, she's our CE provider, will send you an email which has the link to do a short evaluation. She just has an evaluation of how you found the course. So it's a bit of a two-step process, our survey and then her short eval. Hopefully not a big deal for anybody. If you have any problems with that, and we'll touch at this at the end, you can reach out to us here at Metrex Marketing. We'll have our link for that. We'll also email you all these links at the end for attending today. So don't worry about that too. You'll get this information as well. Okay, those are the ground rules. Short introductions of our speakers today. So Sharon Ward-4 is our normal webinar speaker. She's our clinical consultant here at Metrex, has great experience in infection prevention and industry. And with her today is a very special guest. Whitney Casey is our senior product manager here at Metrex. And Whitney brings a wealth of experience from both industry and medical device. She also works at a critical access hospital in her home state of Montana. And as our product manager here at Metrex, she is deeply involved and has a lot of knowledge about material compatibility and instructions for use. So that's why we invited her to give you this presentation today. So she has a wealth of knowledge to share with you on all of this. And we hope it really helps you all out, clear up a lot of confusion we think is out there. Okay, I think that's it for me for now. So with no further ado, I will turn it over to Sharon.
Okay, thanks, Dave. Hi, everyone. Thanks for taking the time to attend this presentation on the FYI on IFUs. Today, as Dave mentioned, we have a special guest, Whitney Casey. She has spent a lot of time during her 3-decade career. She started as a child, trying to understand the complex issues of IFUs for non-critical medical equipment. The information she's going to share today, it's been a real eye-opener for me, and I've been an IP for 14 years, and I hope it will be an eye-opener for you too. But let's first look at our presentation objectives. Okay, we're going to define what IFUs are, to help understand what exactly is required when they're writing these things. We're going to recognize common gaps in IFUs because we sometimes struggle with complying with the IFUs. We're going to explain issues related to cleaning and disinfection. And this is a really important point because there are so many different IFUs for all of these non-critical devices in healthcare, and we worry, how can we possibly meet every IFU? And then we'll also explore strategies that can be taken to improve patient safety, because there are things that can be done when conflict arises with an IFU. So we'll provide some resources that might help navigate paths to resolution. And with that, I'd like to send it off to Whitney. Whitney, take it away.
Thank you so much for that introduction, Sharon and Dave. So as we get started, let's actually define what are instructions for use, or IFUs. So according to the Joint Commission, medical device manufacturers must provide specific instructions on how to properly clean and/or disinfect their devices. So these instructions for use will include things like steps required for cleaning and disinfection, the level of disinfection required. So is it sterilization? Is it high level disinfection? Or is it low or intermediate level disinfection? And I want to point out that this conversation, or this presentation, is going to be focusing in specifically on those low or intermediate level disinfection items. And then it also, the instructions for use also will call out frequency of disinfection and products which are compatible for use with the device. So as a side note, though, it's important that it is not required to call out a specific brand. So IFUs may also include information about maximum number of times the item can be reprocessed, as well as storage requirements. It's important to understand that each patient care item has its own IFU, and it's for cleaning and disinfection. And the expectation is that the organization will follow those instructions. So next. And with that, let's start out with a poll. So now that we've defined what IFUs are, how confident are you that you are complying with all cleaning and disinfection instructions for use for your non-critical medical equipment? And we'll give you a minute to answer that. And I see hosts and panelists can't vote.
I'm watching them vote. We're at about 70%. We'll give you a few more seconds to get your vote in. All right, looks like we've about leveled off. I'll give you the results here, Whitney.
All right. Interesting. So it looks like about half of you are on the confident side, and about half of you are less than confident. And I will tell you that that is completely natural. I hear that a lot. I see that a lot. So this is not necessarily something that I am shocked by.
And
so,
I'll chime in there too and
yeah.
say I'm also half and half. Sometimes you wonder, and sometimes there's just no time to wonder.
Absolutely. Let's go to the next slide, Sharon. So now let's see how your responses compare to those of industry. APIC actually conducted research on instructions for use with their membership from June of 2022 through the spring of 2023. And the results showed a broad range of issues that their membership felt existed, or problems with IFUs. Now, those results included everything from complexity and difficulty to follow the IFU. They included things like instructions don't adequately address cleaning and disinfection to allow a facility to properly clean and disinfect the equipment, lack of clarity, out of date or inconsistent products or technologies that are being recommended for cleaning and disinfection, calling out a specific brand of cleaner or disinfection that may not be accessible to the facility, And those reasons can range from anything from supply chain shortages to GPO contracts or standardization efforts. Broad range of different responses here, and I won't read through all of them, but the areas that I highlighted in yellow are areas that are very directly related to cleaning and disinfection of equipment. And all of these issues are common challenges that I've heard from healthcare providers in my time in industry. And I'm sure that you probably have all faced some of these challenges yourselves. So let's go into the next slide. So knowing that there are so many challenges with IFUs, we looked at what guidance is being provided to healthcare users to help address those struggles with IFU conflicts. And the Joint Commission actually accredits a variety of different types of healthcare facilities, and they accredit about 80 to 85% of hospitals in the United States. So we were particularly interested in what they had to say and what guidance they were providing. They specifically have FAQs that are called Manufacturer's Instructions for Use, addressing conflicts amongst IFUs for different equipment and products, and they have those posted on their website. In these FAQs, they state that when a conflict occurs, that an organization should contact the device manufacturer's technical services team to attempt to resolve them. They also indicate that they can contact the manufacturer of the alternative cleaning and disinfectant product to determine if they can provide additional information about compatibility. And if clear compatibility information is not available, it's left to the healthcare facility to clearly identify what the risks are, the strategies that they're going to use to mitigate those risks, and to implement their risk mitigation plan. So before moving on, I want to address the question that some of you may be asking. So if Joint Commission is accrediting healthcare facilities, why can't they just make a change to the accreditation requirement? Well, the simple answer to that question is that Joint Commission doesn't make the accreditation requirement or the rules. So Joint Commission is one of several agencies that the Center for Medicare and Medicaid Services, which we also call CMS, has deemed status to certify that a healthcare facility meets the requirements to receive Medicare and or Medicaid reimbursement. So in essence, they're serving as the police force of healthcare, ensuring that facilities are complying with the conditions of participation or the rules that are set by CMS. So the rules are actually set by CMS and not the Joint Commission. The requirement to actually follow instructions for use for cleaning and disinfection of non-critical medical equipment is actually called out in the Code of Federal Regulations under the infection control requirements as part of the Environmental Services and Point of Care Requirements section. Now, it's important to understand that there are separate sections of the infection control requirements that specifically pertain to the reprocessing of reusable critical equipment. And that would be equipment that would require sterilization. And there's another section that calls out reprocessing of semi-critical equipment, and that's equipment that would require high-level disinfection. So let's go to the next slide, Sharon. So now that we have a better understanding of who has established the requirements for following instructions for use for the non-critical medical equipment, let's actually take a brief look at how we as an industry got here and how the evolution of industry requirements has contributed to our attempts to improve healthcare, but may have inadvertently made the situation more challenging for us. So over the last century, there are a number of organizations and regulatory agencies that have come into existence. Much of the disease surveillance has originated by the CDC in the mid-40s and ultimately leading to the formal surveillance systems being introduced in the early 60s. This has led to the collection of more data on disease and drove more research into how to reduce the incidence of disease. So by the late 90s, the Institute of Medicine's report, which is called To Err is Human, was released, and it revealed that thousands of people were injured or died in hospitals each year due to medical error. Healthcare-associated infections were recognized as the leading cause of preventable harm in this report. During these same early years, hospitals and healthcare providers were working to establish better standards of care, to be expected. So as a result, in the 50s, the Joint Commission was established, And its roots can actually be traced back to hospital standardization program. And that was established by the American College of Surgeons in 1918. So by the early 70s, APIC, or the Association for Professionals in Infection Control and Epidemiology, was established. And it was the first society for those practicing infection control and seeking to reduce healthcare-associated infections. Also in the 70s, the Joint Commission published the first standards specific to infection control in its accreditation manual. So tracing reimbursement of healthcare through the century, in 1965, President Lyndon B. Johnson signed into law the bill that led to the development of the Center for Medicare and Medicaid Services, also known as CMS. So with federal government now bearing part of the cost, by 2008, Congress mandated that CMS stop providing increased payments to hospitals for the care of patients with HAIs, or healthcare-associated infections. CMS then introduced proposed infection control conditions of participation in 2013, which would require specific measures to further help reduce cost associated with HAIs. These conditions of participation were codified into law in 2019 and are what specifically states that in order to qualify to receive CMS reimbursement, a facility must follow the instructions for use for cleaning and disinfection of medical equipment. Now, in response to the introduction of government reimbursement of healthcare, the 70s also saw the expansion of group purchasing organizations, or GPOs. And GPOs came into existence with the intent of consolidating purchasing for healthcare organizations to drive costs down. And by the turn of the century, membership in group purchasing organizations had risen to 85 to 90% of all medical healthcare facilities. So this is important because GPO focuses on negotiating best pricing for their membership. Their focus isn't on assessing compatibility between cleaning and disinfection products and medical devices. So on the medical side, device side of the equation, while it may not seem to be related, in 2009, the HITECH Act was actually signed into law. And this act required healthcare facilities to show meaningful use of electronic health records. So this in turn has driven more innovation in medical devices to enable those devices to specifically support the transfer of patient care data into EHRs. Not to mention that medical devices are becoming more computer and technology based, and so are experiencing shorter life cycles. This means that device manufacturers are having to update their devices more frequently and will sometimes choose less expensive materials to use to manufacture the equipment in order to keep the costs down. So some of these materials are less compatible with disinfectants. On the cleaning and disinfectant side, the EPA also recognized that pathogens continue to evolve and some old pathogens were beginning to reemerge. So in response, they created a voluntary two-stage process that provided disinfectant manufacturers the opportunity to make claims against emerging viral pathogens not identified on their product label. So if they meet the EPA emerging viral pathogens requirement, they can make additional claims versus what's on their product label. So next slide, please. So all of these efforts have brought more awareness and have magnified focus on HAIs and improved efficiency within healthcare facilities. And it's all with the intent of improving healthcare. So to better understand why this is so critical and the impact to healthcare, it's important to realize that HAIs are the fourth leading cause of death in the United States, and they account for more deaths than things like diabetes, influenza and pneumonia, breast cancer, or even auto accidents. They also account for nearly $9.8 billion each year just for the top 5 HAIs in hospitals alone. So that's an astronomical amount of money. All right, so now let's take a moment to better understand the different groups involved in the process of cleaning and disinfecting non-critical medical devices. There are 3 of them. There's the medical device manufacturers, and they're responsible for the design of the equipment and for providing the IFUs for that equipment. There's also the cleaning and disinfectant product manufacturers, and they're responsible for the design of the cleaning and disinfectant agents used to clean the medical equipment and the instructions for use for those cleaning and disinfectant products. And then there's the healthcare facilities and the users. And that's the group that's responsible for actually cleaning and disinfection of the medical devices. So each of these three groups, they all pretty much have the same goals. Those goals would be patient safety, infection control, caregiver and user safety, improved health outcomes, financial optimization, and ease of use. That being said, it's important to understand that each of these groups operates under a different set of rules and is regulated very differently. So let's start with the device manufacturer. They're regulated by the FDA, and they're required to identify a cleaning and disinfection process for their equipment. They're not required to provide a brand of cleaning and disinfection product. They must call out all processes or brands that cannot be used, but they're not required to call out all products that can be used. And we'll get into how this plays into the scenario in a little bit. But now let's look at the cleaning and disinfection product manufacturer. They're regulated by the EPA, so different regulatory body. And they're regulated by the EPA as a surface disinfectant and wipes. The FDA is notified of these products as a Class 1 medical device, but the EPA has the regulatory oversight. EPA actually regulates these products as a pesticide, and it makes sense because it's killing pathogens, right? So the focus is on killing the kill claims and the test data to support their claims against specific pathogens. Now, surface disinfectants and wipes are considered low-level to intermediate-level disinfectants. The high-level disinfectants and the sterilants are considered Class 2 medical devices, and they are specifically regulated by the FDA and not the EPA. So very, very different animals there. So last but not least is the healthcare facility and user. So medical facilities that receive any sort of Medicare or Medicaid reimbursement, they're regulated by CMS. And these facilities, they must comply with the conditions of participation set out by the CMS to receive payment for services. These conditions of participation are specifically what call out that the user must follow the manufacturer's instructions for use. That being said, if and when changes are actually made to medical devices or cleaning and disinfectant products, there's no process by which the other organization gets systematically updated or notified. And this can leave gaps for the user in their ability to follow the IFUs. A good example of this, let's just say a device manufacturer called out a specific brand of disinfectant in their IFU. And let's say that brand was discontinued or the facility was unable to purchase that brand because there were changes to GPOs. The device manufacturer may not have the information far enough in advance to be able to update their IFU and or complete any FDA filings. So as a result, if the healthcare user wanted to continue to use the medical device, they would technically be out of compliance with CMS conditions of participation, or they would no longer be able to use the disinfectant or if they couldn't get the disinfectant. So if you can't get the disinfectant to clean, you're technically out of compliance with CMS conditions of participation. So with all this in mind, now might be a good time for another poll. So our poll question, have you ever been cited for not following the cleaning and disinfection instructions for use for non-critical medical equipment? And Dave, you'll tell us how we're doing as far as responses here.
Yep, they're very actively hitting it. 60 coming up on 70%. Give them a little longer to get a few more in.
I can tell you, Whitney, I'm very interested in this answer.
I am really interested too. So it looks like About 80% are unsure or no, and just under 20% have said yes. Sharon, is that what you expected?
Actually, I'm surprised that anyone's been cited for non-critical equipment. And I think what comes to mind is that it's going to be stuff that sits out. And I'm wondering if the yes is for glucometers, because those are front and center whenever a reviewer is coming into place to do an audit. So it'd be interesting to find out yes and what that equipment was.
Yes, yes. I know in my facility, we've actually never been cited for that in the 9 years that I've been there. But of course, the facility that I work at part-time is a critical access facility too. So Sharon, in your time, were you ever cited for the non-critical devices?
Sorry, not that I'm aware of. I was in a 900-bed academic medical center for little over 10 years, and we were never cited for any non-critical medical device to my knowledge. But, you know, it just depends on what the area of interest is for the reviewers. Typically, they're going to focus on more things that can cause actual patient harm, like scopes. So again, I see the chat, and I'm wondering if the answer to the yes questions is in the chat. And it'd be interesting, really interesting to find out what everybody was cited for. So maybe we'll take a look at that and see what that reveals.
Yeah, that will be interesting. I can't personally see the chat with the presentation up here, but I'm going to be interested to review that. So let's go on to the next slide, though. So now that we've discussed how all the players in cleaning and disinfecting of medical devices are regulated, let's take a closer look at medical devices themselves. So medical devices are regulated by the FDA. They fall into one of 3 different classes for regulation. Class 3 devices are products that represent the highest degree of risk to patients. And those are the devices like defibrillators, X-ray machines, those types of devices. And they require significant clinical data and pre-market approval or PMAs before they can be sold into healthcare institutions. Then there's the class 2 devices. They represent a medium level of risk to patients, and a 510K must be filed and approved before marketing those devices. And then there's the class 1 devices that are the lowest risk devices. And many of those devices are considered so low risk by the FDA that they're actually considered class 1 exempt. And so a class 1 exempt device does not need to have a 510K filed, but they do need to be registered with the FDA. These are things like hospital beds, stethoscopes, wheelchairs. They're considered to be low risk to patient safety. Let's go to the next slide. So the FDA actually provides guidance to device manufacturers on what should be included in instructions for use. And they specifically call out that the instructions should recommend only cleaning agents or classes of agents that were used during the cleaning validation studies that have been demonstrated to be compatible and with the device and are effective in cleaning the device. The labeling for use on specific medical devices should be consistent with the cleaning agent manufacturer's instructions for use for the product. Now, this is part of good design controls, and it reduces device manufacturers' risks by only calling out what they have tested with the product. And while not an FDA requirement, the Association for the Advancement of Medical Instrumentation, along with the American National Standards Institute and the International Organization for Standards, they introduced design guidance in 2022 that recommends the use of generic name versus brand names of cleaning and disinfection products. They do allow for the caveat that there is no standard test method for testing of cleaning and disinfectant products with finished goods medical devices. So each of these device manufacturers can develop their own test protocols. So as such, there may be some instances where a device manufacturer may need to be more prescriptive in their instructions. By using the generic names of cleaning and disinfectant products, it would not only be helpful for healthcare users, but also for device manufacturers. And it enables them to better support their customers in the selection of the best cleaning and disinfection products based on what is on their GPO contracts and what products can specifically address pathogens of concern for those customers in their facilities. So it would actually behoove them in that case. And so Sharon has moved us along to the next slide. Thank you, Sharon. So when we look more deeply into why it's problematic for device manufacturers to call out specific brands of cleaners and disinfectants in their IFUs, one has to actually understand the product development process. It can take anywhere from 3 to 7 years or longer for the idea for a product to actually go through all the steps required to become an actual product that is for sale in the marketplace. Now, the marketing and design teams, they would typically call out the requirement for a specific cleaning and disinfectant product to be tested on that medical device in the invention and prototyping phase. So it's fairly early in the process. And this means that any cleaning and disinfection product on that device would be at least 3 years old by the time that the medical device came to the market. So that would also mean that any new cleaning and disinfection products that might have broader kill claims or a more desirable usage profile would not be acceptable for use on that device per CMS conditions of participation. It should also be noted that not all, in fact, very few device manufacturers, and especially for non-critical medical devices, as defined by the Spalding classification, very few of these device manufacturers have infection prevention specialists or any deep knowledge or understanding of pathogens. Their expertise, which we all want them to have expertise in this area, is in the design of great products that serve the intended function of the device. It's not ultimately intended for them to be experts in infection prevention. And so the ultimate intended function of infection prevention is a secondary thought in this process. So let's go to the next slide. One slide up. Other way. There you go. All right. Another issue that comes up with the design of medical devices can be found in the exact same FDA guidance document that I mentioned earlier. In that document, it contains a process flow chart that identifies how the device manufacturer should think about the cleaning and disinfection of their medical equipment. Now, remember, most of these companies don't have an infection preventionist or deep knowledge of pathogens. So right here, it states that if thorough cleaning is adequate for non-critical devices that are unlikely to be sources of cross-transmission or soiled by body fluid, it can actually be returned to service. That's without going to the final step of disinfection. So that's a little bit of a red flag right there in the FDA's guidance. This can be particularly problematic, knowing that the FDA has identified Class 1 devices as the lowest level of risk for patient safety, and that many of those products are exempt from 510(k) filings. So this means that many of those devices would not even have regulators reviewing their IFU as part of the approval process. So do you have any idea how many medical devices we're agonizing over following IFUs for that might fall into Class 1 exempt category? Let's go to the next slide. The answer to that question would be 45% of all medical devices on the market are considered Class 1 exempt and only have to be registered, but are not actually reviewed by the FDA. The other interesting thing to consider is how they line up with the infection control Spalding classification. So nearly all of the Class 1 exempt products, by nature of their limited risk, and even a good number of Class 2 medical devices, by nature of their design, do not come into contact with mucous membranes or non-intact skin. So as a result, those devices would be considered non-critical medical devices and are specifically what we have been talking about throughout this presentation. So let's look at another reason that trying to regulate infection control in the current healthcare environment is so challenging. So per the FDA's website, they oversee 175,000 medical devices on the US market. And that represents over 18,000 medical device manufacturers and more than 25,000 medical device facilities worldwide. In addition, they get 22,000 pre-market submissions for new products each year. The EPA, they oversee a large number of disinfectants that are continually being updated and new submissions being received as well. In 2019 alone, there were approximately 850 EPA registered hospital disinfectants. If testing were to be done with all of those combinations between disinfectants and medical devices, it would make it both time and cost prohibitive. So if we take the vast number of medical devices and hospital grade disinfectants into account, we would come up with an exorbitant number of device disinfectant combinations. So let's go to the next slide. So for example, each time a device manufacturer wants to test a new combination of disinfectant with their device, it can cost between $5,000 and $30,000 per device. And it can take approximately 1 to 3 months to complete. So if we assumed testing on just 10% of the class 1, and I'm not even talking about class 1 exempt, I'm talking about that small fraction that were class 1, and 10% of class 2 medical devices with just 5 disinfectants, it would cost up to just under $1.2 billion, and it would take up to just under 10,000 years of time to complete. It's just not going to happen. And if it did, can you only imagine how much this would add to the cost of healthcare? So next slide. So with all of that being said, we still have the ultimate need to protect our patients and to reduce HAIs to save lives. So how do we do this? Well, ultimately, it's time for critical thinking. So going back to the requirements established by CMS in their infection control conditions of participation, one of those specific conditions is that the infection control officer or officers can provide evidence that the problems that are identified in the infection control program are addressed in the hospital's QAPI program. So for those of you that aren't familiar with the term QAPI, it stands for Quality Assurance Performance Improvement. And similar requirements are called out in the conditions of participation for other healthcare facilities. So it's not just hospitals. So, but this is also in line with what the Joint Commission guidance was that we talked about at the beginning of this presentation. Remember where we noted that Joint Commission, their website, they actually stated if clear compatibility information is not available, it's left to the healthcare facility to identify the risks, the strategies, and to mitigate those risks, and then implement their risk mitigation plan. So what Joint Commission is essentially saying, they're basically telling you to the facility to use their QAPI program. So now that can sometimes be easier said than done. So let's say you've identified the problem with the IFU. You have no clear-cut resolution when reaching out to the device manufacturer about whether or not you can use a specific disinfectant. What should you do? Well, per the QAPI process, you would need to identify the problem, assess it, evaluate options, and then control and monitor your proposed resolution. And the biggest recommendations I would make here are, don't do this alone. Involve others in your facility to help assess the risks. And document your assessment and evaluation and your recommended course of action. So with that being said, I'm going to now turn it over to Sharon, and she can talk to you about how you might take those next steps.
Okay, thanks, Whitney. So we have identified the problem, and we wonder what steps can be taken to determine a resolution. So as Whitney said, using our QAPI process and getting our infection control committee and risk department involved, we can begin to build documentation on why we've selected a product, although not the specified product for the device, but one with a compatible profile. And we're focusing on patient safety, and that will explain why we're considering this product. Now, as Whitney said, this is an option suggested by the Joint Commission that we'd like to explore. So using the resources of a paper written by Dr. Rutala, it's in the Journal of Infection Control and Hospital Epidemiology. It's called The Selection of the Ideal Disinfectant, and it's actually a questionnaire. And also, Amy has the technical information report 68 for low and intermediate level disinfection in healthcare settings that provides a lot of good information on evaluating disinfectants with risks and benefits. We've combined these tools and developed a modified version of these documents that we're calling our disinfectant evaluation tool. Now, the tool is designed to be used when evaluating a disinfectant, allowing a comparison of the risks and benefits, because that's really important between products. And it's designed to cover multiple important concepts when selecting the disinfectant. We're hoping the tool, actually the tool will be available to you in an editable format. And we would really like you to try this tool out and give us some feedback, both good and bad. So this is what the tool looks like. There's different categories on it. And the first one is efficacy, because efficacy is really, really important. And the first question actually applies to the 4 different categories. And it's, does the product kill the most prevalent healthcare pathogens, including those that cause most HAIs? And the literature says, if you look at the benefits here, these are the organisms that cause most HAIs. So we've listed that as a benefit, as an example. And we've also listed what the risk would be if your disinfectant didn't, if it wasn't effective against these types of organisms. And we've done the same thing for what causes most outbreaks, MDROs, and actually, most importantly, what are the organisms of concern in your facility? So we've pre-populated this evaluation tool with risks and benefits. I believe you can change those. And if you look on the slide here, we've also kind of tested it against several different disinfectants to give it a score. Now, the lowest score a product can receive is a 0, and the highest score is 10. So as you work through this, we'll go to the next section. So besides efficacy, we've got information on kill and wet times. And some of the important considerations is, does the product keep surfaces wet for the recommended time? Does it have a universal contact time? Because universal contact times are important. That's 1 time to kill everything on the label. We also look at things like safety. Safety is always a concern. You know, we don't want to have to like gown up for Ebola to use this product. We want to be able to use the minimum amount of PPE in order to be safe. And it should also be easy to use, because if a product isn't easy to use, frankly, no one's going to want to use it. We also have things like residue. And of course, we're talking about IFUs on here. And then we talk about other factors that might be important to your facility. Can you get this product? Is it part of your GPO? Will this help you standardize your system? So the goal is, by performing this, that you'll be able to come up with a score that will give you a total of 300. And using that score, you can determine if the disinfectant products are similar or if one turns out to be superior. And it will also give you a clear understanding of the risks and benefits. So we're hoping this will help provide some documentation to begin to build that case for why you're looking at something other than what's recommended. Whitney?
Yeah, so ultimately the question comes back to how can we improve this situation? And first of all, as recommended by Joint Commission, contact device manufacturers when IFU issues are identified. Use them as your first line of defense to try to figure out how to resolve the problem. Now, if that doesn't work, you can always report discrepancies to the FDA if you're unable to adequately resolve the issue with the device manufacturer. And I don't think a lot of people realize this, but there's actually an email and a phone number that's provided by the FDA for making these types of reports. And I bring this up because some of the guidance recommended by the FDA, sometimes when it's interpreted by the device manufacturers, it's not possible for us as healthcare professionals to follow those instructions for use in that advice. So make it known, let them know so that they know how to respond. And Sharon, I know you have some strong opinions about this as well.
Yeah, I completely agree. And as an IP, I never knew that this information was available. I didn't know you could email the FDA. I didn't know you could call them. And now I do. And I think that's really important. I mean, it may take some time to do this, but it's worth beginning the process of notifying them of your struggles with some of these IFUs. And once healthcare begins to build the case that they're struggling, then maybe CMS will pay attention and will start to fix this so that you, the user, won't have all these challenges.
Absolutely. And then finally, if clear compatibility information is not able to be obtained, remember the organization should clearly identify those risks, the strategies to mitigate those risks, and implement their risk mitigation plan per your QAPI process. So let's wrap up with another poll. So were you aware of these paths to report IFU discrepancies to device manufacturers and the FDA? And we'll give you a minute to complete that.
I know I wasn't. But now they better watch out.
Yeah. Well, I've had many conversations with the FDA, so maybe I just use that more than most. All right. So, yeah, I think a lot of you are in the same boat that Sharon was in. I don't think most people realize that that exists. And the FDA, we have to remember that their goal is to provide products that are safe for use and ultimately safe for patients as well. So IFU discrepancies and IFU challenges represent a patient safety issue, as you all are aware.
Right. Absolutely. So IPs, print that last slide out, hang it in your cubicle or your office so that it's readily available. Because again, we need to rely on healthcare to begin to move the ball on changing this whole scenario of IFUs and how they're written.
All right, let's go to the next slide, Sharon, because you don't even have to write that down, as Sharon pointed. We're going to actually send you this slide deck. And in the slide deck, this last slide here, the resource slide, it gives you a link to the CMS hospital infection control worksheet. CMS also has infection control worksheets for other care settings. So if you go to that link, you'll be able to then search for other care settings. But ultimately, the conditions of participation are similar between care settings. That is a great tool. I mean, it gives you a checklist, and it's a checklist that the CMS auditors use when auditing your facility. And then the second link here is the Joint Commission's FAQs that we talked about earlier. If you go to the link, which will take you to the search function within Joint Commission, and you type in manufacturer's instructions for use, addressing conflicts amongst IFUs for different equipment and products, it will allow you to select your specific care area. So if you're long-term care, there's one for that. If you're hospital, there's one for that. If you're ambulatory surgery center, there's one for that. You'll be able to find that there as well. But again, most of them have the same ultimate recommendations that we discussed earlier.